Obesity and metabolic bariatric surgery in children. In this topic, we will discuss the introduction, the impact of stressors, contributors to obesity, screening and diagnosis, evaluation, comorbidities, treatment, pharmacotherapy, metabolic and bariatric surgery. So obesity is a long-lasting, providing negative healthcare effects and attributing morbidity and mortality that impacts a child quality of life. Childhood obesity, it will result in multifactorial set of socio-ecological, environmental, and genetic influences. Individual result in alteration immunologic, metabolic, and epigenetic processes. So as we all know, obesity is a major risk factor for chronic disease, but we are not always aware that the complex interaction of connection between stressors and obesity. So these stressors impact our physiology. These stressors are adverse social determinants, adverse childhood experience, weight stigma, and chronic disease. So the hypothalamic pituitary adrenal axis, it will activate once a patient release stress clinical stressors. And we have secreting of corticotropin releasing factor triggered the ACTH. The ACTH, it will activate the adrenal cortex and adrenal medulla, releasing the cortisol and epinephrine, leading to an increase in adipose tissue and blood pressure. So as a consequence, we have pathologic changes. Contributors to obesity policy factors like marketing of unhealthy food, community factors, family factors like parental behavior and snacking behaviors, individual factors, the genetics, the prenatal and postnatal. Prenatal factors, maternal weight gain. So maternal BMI is considered as a strong predictor for childhood obesity compared to paternal weight. Pre-gestational adiposity and weight gain during pregnancy is associated with a high risk of obesity in children, and we have the maternal smoking. For the postnatal factors, infant with a low birth weight, lower than 2.5 kilograms and more than 4 kilograms are associated with an increased risk of childhood obesity compared with children with a normal birth weight between 2.5 and 4 kilograms. Breastfeeding cessation before 6 months, it will lead to increased risk of obesity in children and overweight by 12 months. And we have the early use of antibiotics. BMI, screen for excess body adiposity, it's calculated by dividing a person's weight in kilograms by the square of height in meters. The child BMI category is determined using an age and sex-specific percentile for BMI rather than BMI cut point used for adult categories. So, as pediatrician and healthcare provider, we should measure BMI at least annually using CDC growth charts for all children ages 2 to 18 years. We should use the BMI adult range in patients age more than 18 years. So in CDC and AAP recommends weight status in children up to 2 years of age be tracked using the WHO weight for length age-specific chart. So we screen for overweight in children BMI more than 85th percentile to 95th percentile, obesity it's more than 95th percentile, and severe obesity more than 120% of the 95th percentile for age and sex. So these are the CDC growth chart for age and sex, appropriate percentile for BMI. We should evaluate by a comprehensive history, physical examination, and diagnostic studies all children with obesity or overweight. In children more than 10 years of age and having an obesity, we should evaluate by lipid panel, blood pressure, and liver diagnostic studies. In children more than 10 years of age with overweight, we evaluate only by lipid panel. We evaluate by glucose abnormalities and liver abnormalities in children more than 10 years of age with overweight and having comorbidities. So we should always evaluate children with obesity and overweight for hypertension by measuring blood pressure starting from 3 years of age annually. So, to diagnose prediabetes, we recommend measuring fasting plasma glucose, 2-hour plasma glucose, random plasma glucose, and HbA1c. HbA1c is the preferred test for monitoring prediabetes. So, obesity in children, it has a high prevalence for comorbidities. One of them, idiopathic intracranial hypertension, depression, non-alcoholic fatty liver disease, polycystic ovary syndrome. We recommend as pediatrician to obtain a sleep history, including nocturnal diuresis, snoring, in order to assess for obstructive sleep apnea. We recommend to evaluate for menstrual irregularities and signs of hyperandrogenism, to assess for polycystic ovary syndrome, to monitor symptoms of depression, and to perform a musculoskeletal review of system, including internal hip rotation for a child and the growth, and to maintain a high index of suspicion for idiopathic intracranial hypertension for any new onset of headache in the context of excessive weight gain, especially in females. So we have a large spectrum of treatment. The most effective treatment should be dose-dependent. It should be individualized to meet the patient's and family needs. Motivational interviewing. We have the intensive health behavior and lifestyle treatment, the pharmacotherapy, and the metabolic bariatric surgery. Intensive health behavior and lifestyle. It is the strongest when it occurs face-to-face. It involves the whole family, and it's a nutrition plan for more than 26 hours involving a change behavior between 3 to 12 months for children more than 6 years of age. So for the pharmacotherapy, pediatricians recommend offering weight loss pharmacotherapy for children 12 years and older. For children younger than 12 years, there is insufficient evidence for pharmacotherapy. We should always refer to pediatric obesity expert for treatment center for prescribing weight loss medication. Metabolic and bariatric surgery. It's a safe and effective for pediatric patients. Referral for adolescents 13 years and older with severe obesity for evaluation of metabolic and bariatric surgery. Laparoscopic gastric bypass and vertical sleeve gastrectomy are both commonly performed in the pediatric age group. Other procedures, they cause subsequent malabsorptions, are not recommended in pediatric population. Metabolic bariatric surgery, it will lead to durable reduction in BMI, as well as a complete amelioration of several obesity-related comorbidities like hypertension, type 2 diabetes mellitus, and change in behaviors. And additional research are needed for children younger than 12 years of age. So, a referral to a comprehensive and metabolic bariatric surgery does not mean the patient will have the surgery. It's an opportunity for the patients and family to have access for information and to have a comprehensive evaluation. Metabolic and bariatric surgery, it will lead to loss of 52 to 70% of excess body weight. It's an earlier surgical intervention are beneficial. It's lead to improvements in BMI and comorbidity. There is no impact on pubertal or linear growth in obesity in children. Complications of metabolic bariatric surgery are minor, mostly in the early postoperative time frame, minor postoperative nausea and dehydration. The major perioperative complication, it will affect only 8% of individuals. Multiple micronutrient deficiency occur after metabolic and bariatric surgery, so a long-lasting follow-up is mandatory. As a criteria, the AAP recommend for metabolic and bariatric surgery, children with class 2 obesity, BMI more than 35 kg per meter square, or 120% of the 95th percentile, with criteria for comorbidity like type 2 diabetes mellitus, NASH, and obstructive sleep apnea. Or class 3 obesity, BMI more than 40, or 140% of the 95th percentile for age and sex, with or without comorbid condition. Autism spectrum disorders, behavioral changes, and trauma are not contraindicated for metabolic and bariatric surgery in children. So age is not the sole determinant for criteria for metabolic and bariatric surgery. Other criteria include lack of medically correctable causes of obesity. So there is no evidence that obesity treatment, it will harm patients' quality of life or contribute to eating disorders. Begin treatment at time of diagnosis. There is no benefit to watchful waiting. Overweight, obesity, and comorbidities should be treated concurrently in children. The most effective treatment is dose-dependent and should be individualized to meet the patient's and family needs and strengths. Referral to a comprehensive metabolic and bariatric surgery when needed is a must. Thank you.